Hey everyone, welcome. We're going to jump right in and get going in the interest of time. This is going to be a very exciting webinar that we've been much anticipating. I'm Michelle Pierce. I'm currently the primary care transformation lead for the Middlesex London Primary Care Network. I'm joined with my colleagues who are going to run this webinar for us. Gord Schachter, who is our Ontario Health Team Primary Care Clinical Lead, and Julie Clark, and Gord is, also an executive council member of the Primary Care Network, and Julie Clark, who is a practicing family physician and also an executive member of our Primary Care Network, and one of the leads involved in our primary care access and attachment project work. So I want to welcome you all here today. And if we can get the slides up.
I think they are my slides, right? Yeah, I'm happy.
Actually, no, we have some intro slides here first, Tara, and
okay, perfect.
then we'll do that. Yeah. So,
and we're going to properly introduce you, Dr. Kiran, and welcome.
Okay.
If we can go to the second slide, we just want to take this opportunity to make sure everyone on the call is aware, if they aren't already, that we have an incredible symposium planned for October 1st, focusing on chronic disease prevention and management. Low cost breakfast, lunch, 6 main pro credits in a beautiful venue. So definitely worth the day, and practical information you'll be able to immediately apply to your practice, relevant to us here in Middlesex, London. And, I guess outside would be Middlesex, London, if you deal with patients in our catchment, or you're practicing in our catchment and a lot of patients outside, you'd be welcome to join as well. And with that, I'd like to hand things over to Gord to kick things off and do some housekeeping.
Sure. So thanks, Michelle. So just so we want to make sure everyone has a good meeting experience, we're just going to ask you to try and stay on mute unless you actually are speaking. There's a raise the hand feature with Zoom, and we're going to leave our questions to the end and let Dr. Kiran do her presentation. There's also a chat available, and so people are welcome to put comments or questions in the chat as well. Myself and Julie will be monitoring that chat and bring those questions forward to Dr. Kiran. If you've signed in using your phone and it says on your name iPhone, then we don't know who you are, which means we can't give you your main pro credits. So if you want to right click on your name, and there's a way of changing your name. I did notice that we do have somebody's, I'm going to go back and look because I can't see all the names, an AI scribe on there doing notes. And so I'm not sure who that person is and why they are sending their scribe and not attending. Nonetheless, I guess we have to make a decision whether we will keep them on there. I guess we can at this point. I will also ask, and people have to feel comfortable doing so, to keep your cameras on. It'd be great to see who you are, especially when questions are being asked. I know that some people are doing this over their lunch and may not want to have their face being seen eating food, but we would appreciate if you can keep your camera on, and that would also be helpful. And lastly, we want to make sure you sign up for the MLPCN newsletter. If you haven't in the past, just going to our website, you can do that. And lastly, we're recording this meeting so that we will be able to post the slides and the webinar online at a later date if you want to review, or people were not able to attend. Couple other things, just a little highlight of what the Middlesex London Primary Care Network is. So just give me a second, I'm just going to move some things. There we go. So we're the PCN is considered the legitimate and powerful advocate for the healthcare system. We're formally thrown through Ontario Health through the Middlesex London Ontario Health Team. We're representing family physicians, nurse practitioners, and all those who have a stake in primary care network. We want to be empowering primary care through unity, support, and connection. So this is just important messaging. We just want to make sure people are aware, who the PCN is. This particular talk, these are our learning objectives, which Dr. Kiran has provided with us. He's going to describe patient and public priorities for primary care in Canada, including views on team-based care, compare the public vision for primary care with the reality today, discuss what next steps we can take to move towards a future state of primary care in Canada that works for patients and clinicians. Lastly, just to make sure we fulfill our main pro accreditation, she has declared no conflict of interest from a financial point of view, And just her speaker disclosure, as she's done a number of talks for various different organizations. So I will stop sharing my screen and just take a minute to introduce Dr. Kiran. So Dr. Kiran is a family physician and health system researcher with nationally and internationally recognized expertise in primary care policy, quality improvement, and health system evaluation. She holds the Fidani Chair in Improvement and Innovation at the University of Toronto, where she also serves as Vice Chair Quality and Innovation for the Department of Family and Community Medicine. Dr. Kiran's research focuses on understanding and addressing gaps in access and equity and quality in primary care, with recent work examining shifts in the physician workforce, the impact of team-based care, and public priorities to reform. She's the founder and national lead of OurCare, Canada's largest public engagement initiatives on the future of primary care, which has shaped policy direction in multiple provinces and informed Ontario's new Primary Care Act. She also hosts Primary Care Focus, which is a podcast that explores how Canada and other countries can build a stronger primary care system. I've been listening to them actively and worth a listen to learn more about what's going on in the international system about primary care and what we can learn from that. She's a family practitioner working at St. Michael's Hospital, Unity Health Toronto, where she's also a scientist at the MAP Center for Urban Health Solutions. Through her work, she is motivated by a deep commitment to improving access to high-quality, equitable, and patient-centered care. So Tara, we'll pass the ball on to you. You can share your slides and move forward. Thanks.
Thanks so much, Gord. And thanks, guys, for having me today. And thank you for that wonderful introduction. Yeah, it's wonderful to meet people, and I'm looking forward to the discussion that we'll have. We're going to talk today about this work that we've been leading on OurCare. And I also hope that, through that we'll reflect a little bit on where we are today as a health system and where it is that we need to move forward. And I think, the most valuable part will probably come in our discussion at the end. Now, as Gord alluded to, I've been a family doctor and a researcher for many years now. And during that time, I think I noticed that, when we're talking about primary care reforms, and we're often talking about reforms because we know the system needs to be better, there was, we often had people like myself at the table, clinicians, researchers, maybe policy experts, people in government, others, but there was often like a really important voice that was missing. The voice, of the actual people who use the system. I would say the most important people, patients and the public. And that's why we started OurCare. It is, as Gord said, the largest ever initiative to engage patients and the public across Canada. Over 16 months, we heard from nearly 10,000 people who collectively spent about 10,000 hours with us, telling us not just about their experiences of care, but importantly, what values were important to them, what issues they wanted to have tackled, and what they wanted to see in a better system. And as we'll talk about, despite the diversity of people we heard from, there was really a lot that people had held in common, and a lot of agreement in terms of where it is that they wanted to see the system go. So over the next while, I'll share with you kind of what they wanted to see, and we'll contrast that with where it is that the health system is today. Um, Overall, OurCare had 3 phases, which I'll talk more about. And it was it was an initiative that was funded, thanks to support I had institutionally, but also through our partners, Staples Canada, Max Bell Foundation, and Health Canada. It was done in partnership with colleagues at Mass LBP, which is a small organization based in Toronto that does citizen engagement professionally. But importantly, it was also done in collaboration with partners from across the country. We had, 2 national advisory groups and 5 provincial advisory groups, with, probably more than 60 organizations all told represented. So you can see there that was the Ontario advisory, and then we had one in each of the other 5 provinces that we were most active in. So this was, I'm speaking about this work, but it was really a collaborative work done with the leadership and help of a lot of people. So to start, let me tell you a little bit more about what we did. OurCare began in the fall of 2022 when we launched our national survey to really understand people's experiences of care, but also, we asked questions about what was important to them and, what their willingness would be to have different kinds of changes in the way that we delivered care. And we published everything we heard transparently on our website, data.ourcare.ca, in an interactive dashboard where you can really play with the results. We heard from overall over 9,000 people, and as we'll talk about, I think there were some really important findings that helped shape the conversation around primary care. But people, of course, have done lots of surveys before, and I think what really made OurCare unique were the dialogues that we had across the country. So our second phase was, really, I think, the centerpiece of OurCare, and these were the 5 priority panels that we conducted, one in each of Ontario, BC, Quebec, Nova Scotia, and Manitoba. In each case, we brought together a group of randomly selected citizens or residents of the province. These were strangers who had never met each other. In each case, we put out a call for volunteers, and then based on the call for volunteers, we actually just randomly selected based on demographics that the volunteers submitted. So in the case of Ontario, there were actually 1,250 people who kind of like raised their hand and were like, yeah, we want to be part of these dialogues. We want to spend 30 to 40 hours with you talking about primary care and trying to solve this issue. And then you can see these are kind of the 8 factors by which we try to just get some representation among that group. And our goal really was just try to kind of get a group that was representative of Ontario. So we think of it as like we're bringing Ontario in the room, and you can kind of see some of that geographic representativeness here on the map. And so, as I mentioned, they spent in Ontario 40 hours and the other provinces 30 hours altogether. And in that time, we started with two or three virtual weekends, and then 2 or 3 virtual Saturdays that were about 4 hours in length each, and then we brought them together for an in-person day that were over, 3 or 4 days. And really, the time together, it started with them doing a lot of learning from experts. We had amazing volunteers, speakers from across the province, who came to talk to them about everything from like what is primary care to issues related to access and rural communities and equity and virtual care. So lots of different topics that were actually shaped by our advisory committee. And then as the process went on, there was more and more time for our panelists to actually deliberate amongst themselves in smaller groups. First, kind of coming up with shared values and then deciding on the issues that mattered to them. And then finally, kind of what were their recommendations for a better system. And so this was the group that gathered in Ontario. This was back in February of 2023 that they gathered in Ontario. And, what was amazing to see, as I mentioned, was this how a group that's so diverse is able and never met each other is able to come together and really build this consensus among themselves about how the things need to move forward. And they presented their findings to senior stakeholders and then actually wrote their own report. And their report is available on our website if you wanted to take a look. But we did this in February of 2023, but then we followed it up with another panel in Quebec. So we did the same process, but it was in Quebec that we gathered in May of 2023, and then in British Columbia in June, and Nova Scotia in July. And then finally, we ended in Manitoba in October. And in each case, it was a very similar process, but really grounded in the provincial context and issues and expertise, so that the dialogue was provincially specific. But the structures were the same in each. The structure and outline was the same in each case. And so each of these reports you can find on our website. And we did try, as you can tell from the way that we randomly selected, to really make these engagements inclusive. But we knew that we were still probably missing some important voices through our first and second stage of OurCare. And that's why we launched the third phase of OurCare, which are our 10 community roundtables. So these were one-day sessions that we held, 2 in each of the 5 provinces, in partnership with community organizations that had established relationships with members of marginalized communities. And it was really these community organizations that brought people together, for example, people from Indigenous communities, people from Black communities, newcomer groups, people with disability, members of the LGBT community. And the idea with these one-day sessions was to really bring voice to, what were the specific issues that mattered to these groups? How did they differ, or how were they similar to the ones raised by the priority panel? What were some of the unique recommendations that these groups might be putting forward that we might have missed, for example? I think we've tried really hard to make these as inclusive as possible. One thing that's pretty neat is, like, many of them actually were simultaneously translated. So our one, for example, with the Umbrella Multicultural Health Co-op in Vancouver was actually simultaneously translated in 5 languages at one time, which is kind of amazing. I think really so many of these groups, I think, really were a reflection of just like the diversity of the voices that we have here in Canada and the perspectives that we need to keep in mind. So all told, with each community roundtable, we published a report. With the survey, we published a report. So we have about 17 reports available on our website at ourcare.ca that go more in depth into each of the findings with each of these consultations. But then we also released in February of 2024 a final report. And this final report really summarizes everything we learned through our journey and introduces something called the OurCare standard, which I'll talk about in a moment. But before I do that, I did want to spend a few moments actually just sharing some of the voices of the people that we heard from, because I think it really brings to life who it was that participated and why they did so. And importantly, they talk about what they learned from the process, which I find really interesting. So I'm going to take a moment to just show this short video to you, and then we'll talk more about the OurCare standard.
I volunteered to be a part of the OurCare panel because of my own health issues. I struggled between having a doctor, losing a doctor, and then having a doctor and losing a doctor, and being resorted to walk-in clinic, which has not been able to help me in my own healthcare needs. And I wanted to be able to provide our voice to the people who make policies in order to try and make it a better experience for other people going forward.
And knowing that my generation is going to be inheriting this very important system, I feel like it's my duty as a citizen to do my best to build the system and improve it so that it can be sustainable for the long term.
Ce que je trouvais qu'on a en commun, c'est chacune de ces personnes-là qui sont ici présentes, de ces collègues, ils sont ici pour le même but, de se faire entendre et d'apporter d'amélioration.
I'm not as alone as I maybe thought I was. Everybody, even though you have different backgrounds or different histories or different needs, all really at the end of the day wants the same thing, which is a healthcare system that works for everybody.
Whoa, okay, I'm not the only one, and to realize that a lot of people have the same goals in mind in regards to healthcare and how they want to improve healthcare.
I felt like I was a pretty good navigator of our healthcare system and found out there's so much I don't know. And so if I don't know as someone who thinks I know quite a bit and has used it a lot, how much do other people not know?
To bring 36 people together with varied backgrounds from various parts of the province to get together and literally in less than 2 full days of working, we're developing strong, actionable recommendations.
Because I know personally I'll take whatever I've learned over the last 4 days back to my own, town and area, and try and continue the work that I've come to realize as being important here in the group.
I have learned way more about how the healthcare system in this province works than I ever thought I could learn this quickly. I've also learned, though, that the answers to the current crisis are probably in the room with us. We just need to get the right people to listen.
So you can see there the passion behind the people who volunteered for this process. They did it to make the healthcare better for everyone, not just themselves, for people here now, future generations. And we're really grateful for all they learned and wanted to have others learn similar things too. And I think we're also just taken about how there was this shared experience that they didn't realize was a shared experience really until they got in the room with others. And so I think watching these conversations unfold was quite special to see the consensus that was built in each conversation, but also when we looked across reports, there was a lot that was in common. And we tried to capture that in what we call the OurCare standard. The standard is 6 simple statements that describe what every person in Canada should be able to expect from the primary care system, and is really a distillation, we think, of the core concepts that we heard again and again through our consultations. And I'll just go over them briefly with you here, and you could read our reports for some more detail, but I do think it's important for us to reflect and continually think through these 6 elements as a potential North Star for where it is that our system should go. It starts foundationally with, of course, people feeling very clearly that every person in Canada should be able to access primary care, ideally with a relationship with a clinician. They thought that clinician should work with a team, and there were multiple reasons why that was, but I think they understood that with the current health human resource challenges, that really for everyone to have access, we would need teams, that teams would make hopefully the practice environment better for physicians and others. And I think also that teams would provide them with more comprehensive care. And they wanted that, of course, to all remain within this publicly funded system. It was important to them that care was ongoing, but also timely. And that included care that was in the evenings and weekends, and virtual care integrated with in-person care. And they specifically talked often about virtual care being used to actually enhance equity, particularly, for example, in rural communities. They wanted our system, the 3rd standard really speaks to this idea that they wanted our system to be wellness-oriented and not sickness-oriented. And they wanted primary care to be connected then to community and social services that could support overall well-being and address social determinants of health. The 4th standard really comes from, over and over again, how commonly we heard people being frustrated that they couldn't access their own medical records and the challenges that presented. And so that this idea that everyone should be able to access that record online and share it with their clinicians and caregivers. And the 5th standard speaks to us having a culturally safe system and relates to us hearing about lots of instances of racism and discrimination that continue to happen within our healthcare system and that we need to acknowledge, address, and ideally eliminate. And that, the care that is provided needs to meet the full range of needs of people. It's not okay to just go to a family doctor and then be told, or go to a primary care practice and be told that, addictions, we don't do that, or we don't do gender transitioning, people's full care needs need to be able to be met within the primary care setting, or being supported, through referral basis, etc. And, when we think about the culturally safe care, it was clear that in spaces, it was important for people that the people delivering the care reflected the community diversity, and that was an important way of ensuring these spaces were culturally safe. And then the last standard really talks about primary care being accountable to the communities that it serves. And I think that incorporates a few different things. It incorporates just transparency about like what is being done, how much money is being spent on primary care and what we're getting for that money, what the performance of the system is. But then it also relates to patients and the public being involved in not just care decisions about themselves, but also in the direction setting of the system and, service delivery. And also patient and public empowerment so that they're educated around, caring for themselves and navigating the system. So these 6 standards, are really what I think need to be the North Star for our system, set the direction, but also, is a way for us to evaluate to what degree is our healthcare system really meeting the needs of people in the way that they wanted those needs to be met. And so over the last while, as we think about this, I think it's worth us just pausing to think about, where are we now in relation to what it is that people put forward. And so in the months leading up to the publication of our final report and the months afterwards, we did meet with a lot of different stakeholders, senior stakeholders in different provinces, to talk to them about the standard and what we learned from our conversations with people. And, just a few months ago, sort of the unthinkable happened almost is that, the elements of the standard were really adopted and integrated now into a first of its kind legislation that was passed in June of 2025. And so, as you know, Ontario passed a Primary Care Act in June 2025. It is the first jurisdiction in Canada to have such an act. It's a really short act if you want to read it. It outlines primary care as the foundation of the healthcare system, which is, I think, really important step. But then it also lays out 6 very specific objectives for the primary care system. And what was wonderful to see was that these 6 objectives match concept for concept the OurCare standard. And they're really inspired and taken from this work and the voice of patients in the public and what it is they said was important to them. So I think this is really wonderful news for people in Ontario, and I'm hopeful for people across the country because I'm hopeful that this is just actually the first step of many. And as you know, the government, my hope is that this is not just words on paper. It is important to note that as part of this act, the government is actually required to report on the primary care system on an annual basis. And I'm looking forward to those reports, and I hope it's a way to keep government accountable. But we know that we also need to do our part to just ensure that we're continuing to move in the right direction. And so our team actually just launched this past spring a second survey, the OurCare 2025 National Survey. And our goal here with this survey was to really understand to what degree do patients' actual experience of care measure up to the OurCare standard. And so we have some of the same questions as our first survey, but some of the questions are different because all of the questions reflect different elements of the OurCare standard. So the survey now is closed except for people in the territories, and our hope is that we'll have results by the end of this calendar year. But just to, let people know that our previous survey, there were, I think, some results that are worth us reflecting a little bit on. And of course, I think one of the headline findings from our previous survey was just that, more than 1 in 5 people in Canada don't have access to primary care. That's the case nationally. It is worse in some regions and better in others. And actually, importantly, Ontario is actually one of the regions that it's better in. So as bad as it is in Ontario, it's actually a lot worse in regions like Quebec or British Columbia or the Atlantic region. And in our coming survey, we're going to be doing really province and territorial specific sampling so that we are able to really get a more fulsome national picture of primary care access. But importantly, like even people who did have a family doctor were still, of course, struggling to get care, with 55% saying that they always or usually could get care from another clinician. Only 44% saying that they had someone in their practice that was able to help with urgent issues outside 9 a.m. to 5 p.m. Monday to Friday. And that, only 39% said that they were able to get an appointment the same or next day for an urgent issue. And just to say that, this actually is a lot better than the national average again. So in Ontario, this is, even though this is suboptimal in terms of where we want to be, it is actually better than the national average. What we also did see confirmed in our survey and what we, of course, heard from our dialogues is that there was strong support for team-based care, with 88% saying that they were comfortable getting care from another team member if it was recommended by their family doctor or nurse practitioner. But we know that, that willingness and interest in team-based care is really in contrast to where we are right now. So this is some unpublished data that we just kind of gathered, and just to say that, the blue is the family health team model, and you can see the growth in the model in the early decades until probably about 2012, 2015, and then it kind of stagnates in terms of the number of people. These are number of people in Ontario that are attached to various models. And so it kind of plateaus at about 25% of the population belonging to a team-based primary care model. We know, of course, from recent announcements that hopefully that's going to change, but it is an important touch point in terms of where we are right now. And importantly, this variation in who has access, as many of you might feel, like there is a huge variation by region. So this is something we published in Canadian Family Physician earlier this year, and you can kind of see in areas like Scarborough, over 90% of people have no access to a team. But in Georgian Bay, it's actually, less than 10% that don't have access to a team. So just like incredible variation, with actually, many regions in the GTA, Scarborough, Mississauga being the ones that have the least access to teams. And so not only is there variation, but I would say this variation is not rational. And I think my colleague Rick Glazer did some really important work several years ago to show that the areas with some of the highest needs in Ontario, whether that's urban or rural, actually have the lowest per capita number of teams. So not a rational distribution, and if anything, the inverse care law. Now, despite that, the inequity in how teams are distributed in the population, I think important to kind of acknowledge how teams that are there are affecting care. And some of the work that we've done has shown that, teams are associated with improvements in diabetes care, and also with patients being less likely to have increases in emergency department use over time. So there has been, we think, some positive impacts of team on the populations they serve. Interestingly, I think one of the reasons, though, behind the push for teams now is that we think it can actually support us to serve more people, because we know we don't have enough family doctors to go around at this time. And some unpublished data, this is kind of hot off the press, shows that really family health physicians and family health teams, even if we look at, physicians working more than 1.0 FTE and working in urban areas and stratify by physician gender, we don't see any substantial difference in team-based models versus non-team capitation models. And if anything, actually the team-based physicians have slightly lower roster sizes. It's not a perfect kind of comparison because we don't have hours worked as a variable, just sort of some proxies for that. But I think it's fair to say, based on the stratifications we've done, that we're not seeing team-based models certainly roster more people, and if anything, it's the same or less. So, I mean, I think there are some lessons as we think about implementing teams that we can reflect on. I think, for one, I do personally feel that, physicians need to be able to work effectively in a group, cross-cover and share records in order for other health professionals to be able to effectively integrate with them into a broader team. And I think that sometimes that's been heterogeneous or variable across our province. And I think some of the challenges with access or optimization sometimes are related to this issue of, physicians not necessarily working as a group before layering on the team. As we talked about, I think we do really need to be clear on the objectives for a team. And I think when family health teams were introduced, I say this as a former board chair and a former quality improvement director at our own large family health team, rostering more patients wasn't the specific primary goal. There was lots of other things that we needed to report on. And I think we need to be very clear now that probably our most important goal is to serve more people. Not necessarily increase the quality for the same people that we are serving. And often that means using our teams in different ways. So for example, having nurses do more substitutive care as opposed to duplicative care that, they can take on independently, for example, as opposed to just adding more care to the same person, which is, I think a challenge that we see in some of the team models already. And then, of course, we've talked about equity and how, from a population perspective, we really need to ensure that if we don't have teams covering the whole province, that we need to start in the places that need the teams the most. And I will say that patients really concurred with that. So, when we look at some of the recommendations related to teams from patients in the public, we saw in at least 3 of the provinces, the panelists saying that, we need to start team expansion in areas with the greatest needs. People were particularly, I think, taken with the community health center type models where there was community governance. And I will say in Ontario, there was this very specific recommendation as well to integrate walk-in clinics into team-based models. So that was something that was, interesting that the Ontario panelists brought up. I will also just share this one quote from our Ontario report, which I think is worth us reflecting on. And this is this idea that we should be thinking about primary care like the way the public school system is delivered, and that, to ensure that every Ontarian has a primary care home, they say the government should move towards automatic rostering, similar to the public school system, so where everyone is like assigned a team. And while health teams should be mandated to accept any patient from their catchment area, it's still important to maintain an element of patient choice. And in the report, they actually go through kind of how that choice might be able to be maintained. So some really thoughtful recommendations in that report if you want to check it out. But I think this whole journey for me has also helped me to reflect on the current state, in terms of where we're at. And I think this real unfairness that we see among people in Ontario and across the country. Some people, the haves, who have access to, let's say, a family doctor, some who have a family doctor plus like other health professionals working in their team, including, my patients who see me in this clinic. And then at the same time, we have a whole bunch of people who have nothing. And so it's just really inequitable situation. And I think we have to think very carefully about how we can reconcile our resources at a population level so that it is more fair, that we don't have the haves and have pluses and the have-nots, but at least everybody has a have something maybe. And so I think that's our challenge in primary care today and at the health system level. And I know sometimes it can also feel really out of our hands when we think about policy and what needs to be done. And so, I mean, I've put here on the slides, I think, some questions that we can think about in our discussion around, how can we as family doctors, as leaders in family medicine, in primary care, how can we advance the public vision that I put forward? And I think some of this relates to, how can you design your own team to serve more people? What would be needed? And how much would that cost? Like, is that something that you're able to put a proposal together for? Do you have existing resources that could be repurposed? Are there new partnerships that would be helpful? And does your team provide the full range of services that people need? Do you have the expertise within your team, for example, to provide opioid agonist treatment or to serve people who are on opioid agonist treatment, as an example? How does your team ensure accessibility? Are there barriers that need to be removed for people with disabilities or people who use different languages or are more comfortable in a language other than English? How are you addressing racism and the legacy of colonialism? Can patients at your center access their own records? Is there a way for you to help them to do that? And how do you empower and remain accountable to the communities that you serve? I think these are some kinds of questions that we can reflect on and potentially think about actions even at our local level, at the team-based level, and certainly at the Ontario Health Team or PCN level. And so it's with that like, I think we should, think through how we can achieve this standard together over the next little discussion period. And I guess and also by sharing, as I've been thinking through how we can achieve this, one of the things I have been trying to do is just share stories about what's working. And as Gord mentioned, sometimes that means I've gone to other countries to kind of learn, like, what is it that we can take away from how they're doing things. But what I've also seen, and we're just going to launch season 2 in September, I'm going to feature a number of practices in Canada, because I think there are examples of really high performing practices in Canada that we can learn from as well. So check out my podcast if you want to dive deeper. But with that, thank you so much for having me today, and I look forward to our discussion.
Thanks, Tara. Great to get to take on the slides. So I just wanted to give an opportunity for hands up from our crowd here. If anybody has any questions or comments they'd like to discuss with Tara. It's a quiet group, don't feel. I'm going to pull, actually, thanks, Julie. Go ahead.
I'm curious to ask you a question about the 6th point, which I'm just wondering, what are some sort of practical ways that you or all the panelists have thought of for accountability? How we can be accountable in a local sense?
Mm-hmm. Yeah, great question. I do think like the most basic level is transparency around what you're doing. For example, do you have an annual report? I don't know the context from which you're working, but, are you a family health team or community health center that might have an annual report? Is that actually like available on your website? Are you sharing very broadly, like whether you're accepting new patients and what kind of services you are providing? If you are an OHT or PCN, are you talking about what investments are coming your way and how you're spending that money and what's happening as a result? Do you have performance metrics, maybe your quality improvement measures or our patient experience survey results, for example, that you're collecting that you could share? So I do think transparency is the most basic. And interestingly, like, at a health system level, we looked across the country and really there was actually only one province, New Brunswick, that like was regularly reporting on the performance of its primary care system. And so to me, this is kind of pretty low-hanging fruit. I think the other piece relates to patient and public involvement in service delivery or design. So one thing that I'll just say is, as I actually was on an academic leave for a year following OurCare, and so I had the opportunity to, and also to explore care in a few other countries, including in Spain. And actually, they have teams that are very community oriented. And one of the that they do is they actually partner with epidemiology who's able to understand how their demographics of their area have changed. Now, I'm not saying all of you guys have to do that, but there is some of that data available publicly around how has your demographics changed. But what's interesting is that they do like focus groups also with community members to say, you know, what are the things that are most kind of on your mind? What are the things that you want answers to? And that helps for them to figure out what programs to deliver. And so, not to say that you have to run a formal focus group or anything like that, but is there a way that you can understand from the community what their most important needs are and figure out whether, you know, the PCN collectively is able to meet those needs, as an example? So that would be another piece. And then the last piece is just like education and empowerment. And I think some family doctors are already doing that by, like, for example, through their websites or email newsletters to patients, like trying to provide as much information to patients as possible to support them to better navigate the system. And ideally, we would be doing that even better at a provincial level. And I think Health 811 is improving and getting us there to some degree, but there's still work to be done there. So I hope that answers some of your questions.
Thank you. Yes.
I noticed Keith Thompson put in a lot of
Yeah, maybe
comments.
I'm just going to summarize one of the things that you can comment on. So we know that, and you know, putting it in the spot, we know that the OMA and the government have made some negotiation changes. We're introducing the full plus model, which should be introduced as April 1st. And there are other elements that are still under arbitration, but there's been some things that have been agreed upon with the full plus model. And so I'm just wondering in your thoughts on how you see some of these changes in the full plus model being pro or con and affecting primary care and the needs that patients are desiring from our primary care system.
Yeah, I mean, I think fundamentally, my hope is it translates to a raise for family doctors and encourages, partly for that reason, more people to go into family medicine. That also by acknowledging, I think, the amount of time spent on not direct patient care, but indirect patient care activities, that also helps to recognize the incredible amount of work that family doctors are doing and not feeling recognized for right now and not being often recognized for. And so my hope is that fundamentally this means that family medicine becomes more attractive to people, and that through having more family doctors doing full service family practice, we're able to address some of the attachment issues. There are, of course, also new bonuses for, or new incentives, financial incentives for attachment. I think what isn't clear right now is, you know, how are we going to ensure the timeliness and continuity that people want? Because it's not just about, do people check the box, have a named family doctor and nurse practitioner, but whether that is like actually a meaningful relationship and someone that they can see when they need to. And so I think that's something that has yet to be seen. I know that there is an elimination of the access bonus. My hope is that that enables more coordination of care, for example, shared after hours care, and maybe even more collaboration with walk-in clinics, or regional collaborations through a PCN. So I think there's a lot of opportunities with the new Full Plus model, but at the same time, you know, there are always some unintended consequences that we need to be wary of. And so let's see how things go with the implementation. But at the most fundamental level, I hope that the pay raise increases the respect and interest for family medicine.
Thanks, Terry. I know it's putting it in the spot a little bit different than what you're talking about, but I think it's important to put it in the context of what our system is right now and how it's changing. So, Vineet, we'll let you go next with the question.
Yeah, no, thanks for the presentation. It's really interesting stuff. And I guess my thoughts are, a lot of things a lot of thoughts going on in primary care these days. I guess it's sort of like, it feels like the work is really good. I'm wondering how much of that is going to the higher ups in the province kind of thing, because I feel like something else is great, but a lot of these things are out of our control as a primary care, even I'm the PCN co-chair, and like it feels like, you know, we have all these things happening right now, and we're all yet being forced to do it on our own, either at the practice level, the PCN level, the OHT level, and there's not any unified provincial plan. They have some ideas that we should do, but how we do it is all up to us, and it seems a bit daunting for us. And so I find that's one of the challenges. And then I think just what you're mentioning just now is that, yeah, I agree. There's probably some hierarchical priorities. Like, I think one thing is just getting more people going into family medicine as the whole, and then we can kind of work out the other stuff afterwards. But that's probably the first thing that'll really kind of get the ball moving in the direction we need it to go. But yeah, just wanting more thoughts about the provincial direction that we could have. Stop us all doing small little projects on our own and trying to figure this out on our own, and instead of having some sort of direct guidance, when we kind of know where we're trying to head to, but we're just all left to do it to our own devices to kind of get there.
Yeah, I can completely understand where you're coming from. I will say that, over the last 18 months or so, I guess I have had the chance to share, this kind of presentation, but also kind of this in the solution space with many different people at senior levels. So they're very well aware. So whether that be the Ministry of Health, the Ontario Health, the Minister's Office too. So I think those are three kind of very different, and then also the Premier's Office. And I think that, it really was a collective effort from many different people to get family medicine in the spotlight that led to the formation of the Primary Care Action Team and the $1.8 billion commitment for primary care. And as many of you might know, but you may not know, so Jane Philpott, she's been hired for 5 years in a full-time role. And this is someone who worked as a family doctor in different settings and also was, of course, the dean and the former Minister of Health. And so she knows primary care really well, and I think she does understand these issues. You also have folks like Liz Mugga in Ontario Health as the primary care. She was the primary care lead, and now I think has a promotion. I don't remember what her new title is. But just to say that I do think all the things you're talking about, like people get that these are issues that need to be tackled. And I'm myself very transparent with people, like, it's one thing to pay us for admin time, but ideally we don't have the unnecessary admin work. That would be better. And, we need to have patients share, patients have access to their records, better information systems, HRM that doesn't like make our workday a nightmare. Like they know those issues, but I do feel now that there are more people working on them with more accountability for it, if that makes sense. Like that this act was passed, they have to report on it every year. $1.8 billion. Jane Philpott and her team have to report to Treasury Board on what the outcomes are for that money. So I am hopeful that there are going to be changes at the provincial level. I guess what I would say in terms of the connection of the local and the provincial, because it is too much, like I mean, there's so many things we could talk about in terms of and what they are concretely, and I don't think that was your question, but just in terms of the interaction between the two, I mean, I think what is great to have happen is if at your level you can see what the solutions are or can demonstrate them and share that, that's always very constructive. And by that, I also mean like you can tell, like, oh, these people are unattached in your community and you know what it would take to actually attach them. And I think where they can't have a one size fits all because communities are very heterogeneous when it comes to those kinds of attachment issues. And so I think having local leadership to say, this is actually how we could solve the attachment problem here, this is what we need, I think is very, very strong. And then, of course, I do think there are organizations like the OCFP and OMA are putting forth some of the broader kind of pain points, but I think the solutions at the local level is really what's needed and would be great for you guys to share. I agree with you that there is a lot of reinventing the wheel, it feels like sometimes, and that can be very frustrating.
Thanks, Tara. And seeing a bit quiet, and so just knowing that we have 5 minutes left, I just wanted to thank you for coming today to talk to us about the OurCare project and the OurCare study. I think I'm going to highlight a couple things that from the standards that are really important that I think are trying to dispel some of the myths that we are hearing sometimes in the trenches, is that patients are happy to see other team members. They just want to know that their MRP, their nurse practitioner, their family physician is aware and it kind of endorses it. Really important. So they're happy to see those other team members. And two, there is some evidence to suggest that the team's actually maybe improving outcome and reducing emergency room visits and costs. And so that evidence for the effectiveness of team is really important. I just wanted to highlight that you've sort of shared with us.
And maybe just add to
Yeah,
that.
go ahead. Yeah,
Or,
go ahead.
you know, I do think that one of the other things we've heard again and again is like that informational continuity is important. So relational continuity, so when seeing the same family doctor or nurse practitioner again and again over time is of course wonderful, but can't always happen in, you know, if people are out of the office, etc. But people have been very clear that, you know, that in the absence of that, having the information, their information, be able to be seen by other people is really critical. And so I think as we're setting up our teams just to really ensure that we have cross coverage with informational continuity, I think is really critical.
Thanks. And I will also, again, make another comment that with the introduction of the full plus model as of April of next year and elimination of the access bonus, it actually gives us the opportunity to look at how we could provide after hours care as a system differently. And, you know, listening myself to what you were talking about in the Netherlands and how they run after hours care, we have the potential to start rebuilding how we do after hours care to look at a better process, but we have to be bold and willing to take that leap of faith that something could be done differently. But we have that potential now with the changes in that full plus legislation. So thanks. I'm going to mention one last thing to our group here. Sometime in the next 20 minutes, if you're a PCN on the PCN email blast, you're going to get an invite to what we're calling a knowledge exchange event that's going to be talking about neighborhood health homes. It's sort of for preparing for the integrated professional team round 2, which will be coming sometime in the fall. So if you're a provider who decided not to be involved in that round 1, but have some interest in learning more of how it can be involved in round 2, or if you're a provider involved in round 1, you're going through working with the team on implementation still, to hear your voice will be helpful. So there'll be some invites. It's going to be an evening session in person. So that invite should come to your inbox. I think it's being planned for a 1:30 email blast today. So and it's just a follow-up to Dr. Kiran's talk and to our talk next Thursday, which is Dr. Noah Ivers, who will be joining us at 12:15. And you should have that invitation as well. So thanks very much.
Thanks for having me, Gord and team. So nice to connect with you, and hopefully I'll get to meet some of you in person one day.